Okay, welcome. Okay, in this section, we're going to talk about cardiac conditioning as individuals get older, plus this. But yeah, I'm Dr. Marty Wice, and I welcome you here. This afternoon, we'll be talking about cardiac conditioning, particularly how it's involved with the elderly, as well as cardiac conditioning and the special concerns of people who've had polio. We'll start out by having Dr. Michael Rich, who's a professor of cardiology at Washington University Medical School here in St. Louis, talk to you about cardiac conditioning and the elderly. Then I'll talk about specifically the special issues with polio. Okay, thank you.
Thanks, Marty. Good afternoon. So as Marty mentioned, I'm a cardiologist at WashU. I'm a general cardiologist, but for the last 25 years or so, my main interest has been in cardiac aging, the effects of aging on the heart and the blood vessels, and cardiovascular diseases in older individuals. And I'd like to just start with some general comments about aging. Some years ago, I wrote a column in one of the medical journals entitled "Aging Happens, But Why?" And I think that still is a very important philosophical, societal, medical, and scientific question today. We all recognize readily the differences between a 5-year-old, a 25-year-old, a 45-year-old, a 65-year-old, an 85-year-old. And what causes those differences? Well, what we're seeing is the effects of aging, the effects of normal aging. Why does that happen? And is there anything that we can do about it? And I'm going to talk mostly about aging of the heart and blood vessels, but I think it's important to recognize that that aging occurs throughout the body. All of the organs, the kidneys, the brain, the reproductive system, lungs, all are affected by aging. The most obvious and visible, and the thing that we recognize, is the changes in the skin and the hair. So, for example, my head did not look like this 40 years ago. I had a beard 40 years ago, but it wasn't this color. So those are the effects of aging. And so I thought that I would begin, just so that we're all on the same page. This is an outline of my talk. I'm going to talk first about normal heart structure and function, then the effects of normal aging on the heart, and finally try to provide some insight into the obvious question of, is there anything that we can do to slow the aging process? And so in order to kind of make sure that we're all on the same page, I'm going to do a quick review of the heart, the parts of the heart, and how the heart works, so that we're kind of all on the same pages, and then talk about the effects of aging on the heart. So this is a normal chest x-ray, and you can see the heart is located immediately behind the breastbone. It's about the size of a fist, and it's a little bit more towards the left than to the right. And if you feel your heart in your chest, you feel the heartbeat more on the left side than on the right side. But it's on both sides, just slightly more to the left. On either side of the heart are the lungs, and then below the heart, the diaphragms, which separate the chest from the abdomen. This is the normal anatomy of the heart, and the main thing I want to point out here is that the heart has 4 what are called chambers. There's 2 upper chambers called atria, or atrium, and there's 2 lower chambers called ventricles. There's 2 on the right, 1 right atrium and 1 right ventricle, and 2 on the left atrium and the left ventricle. And the function of these chambers is that the right atrium receives the blood back from the body, and I'll go into a little bit more detail about this on the next slide. The right ventricle, the blood moves from the right atrium to the right ventricle, which then pumps the blood to the lungs, where it collects oxygen, and the left atrium receives the oxygenated blood back from the lungs, and then the left ventricle, which is the main pumping chamber of the heart, pumps the blood out to the entire rest of the body. So if we look at the normal circulation of the heart, and in the middle here you see the heart, above it is the lungs, and below it is the rest of the circulation. And starting from the left ventricle, the main pumping chamber, the blood goes out through a large artery called the aorta, and then that branches into progressively smaller arteries, and eventually will lead into what are called capillaries. And capillaries are very, very small blood vessels that are so small that they only allow a single blood cell to pass at any given time. And that's really where all of the action is. At the level of the capillaries, the blood cells release oxygen into the tissues and also other nutrients, and at the same time collect waste products, including carbon dioxide and other waste products. And it's always depicted that the blood on the arterial side, before it gets to the capillaries, is redder. It often is a bright red. And on the venous side, after it passes through the capillaries into the veins, it tends to be a bluer color, and that reflects the release of oxygen. So if you look at the back of your hand and you see those bluish vessels, those are all veins. The arteries are deeper in the system, and you have to go in sort of with a knife or something to reach an artery or a needle. So after it goes through the capillaries and picks up the carbon dioxide and the other waste products, goes into larger and larger veins, returns to the heart at the right atrium, then goes into the right ventricle, gets pumped out to the lungs, where in the lungs the reverse process happens. You have capillaries in the lungs, and the carbon dioxide that's in the blood at that point is released into the lungs, and then you blow it out as carbon dioxide. And at the same time, the cells pick up oxygen so that when they return back to the left side of the heart, it's now a red color again, and it's carrying oxygen that can be then recirculated out to the rest of the body. So that's the normal circulation of the heart. The heart also has a series of 4 valves, of which only 3 are shown here. The function of the valves is they open and close with each heartbeat to make sure that the blood keeps flowing in a forward direction. If there were no valves, the heart squeezed, there was nothing to keep it from going backwards. And so the valves have a specific sequence that they open and close to ensure that the blood goes in a forward direction. If you know anything about cars, they work exactly the same way as the valves in a car. The heart also requires blood in order to function, and so the blood supply to the heart is from what are called the coronary arteries, or the coronaries. There's 3 main arteries which are depicted on this slide in red, and normally these are wide open arteries. The blood flows easily through them to the heart muscle, but blockage in these arteries can reduce blood flow to the heart, and if it's severe enough, may cause chest discomfort, which we call angina, which is most commonly experienced as a tightness or a pressure or a heaviness in the chest, something along those lines. Sometimes it feels like a pain, but most people don't call it exactly painful. They'll call it a pressure or heaviness or a tightness. And if there's a sudden blockage in one of these arteries, if a blood clot forms in one of these arteries, then the blood supply to that area of the heart is completely cut off, and that's what we call a heart attack, also called myocardial infarction in medical terms, or an MI. And when that happens, there's damage to the heart muscle, which is ultimately irreversible. And depending on the amount of damage, the location of where this blockage occurs, that will determine the size of the heart attack and what the long-term outlook will be. The heart also has an electrical system, and the electrical system regulates the heart rate and the heart rhythm. So the heart beats normally, regularly, certain number of beats per minute, and that's regulated by the electrical system. The electrical system also ensures that the heart beats in a coordinated fashion. So normally, the upper chambers or atria will beat first, push blood into the lower chambers, get the maximum amount of blood into the lower chambers. Then the lower chambers will beat and pump the blood out to the lungs, the right ventricle, or the body, the left ventricle. And some additional things about how the heart works. The heart is a specialized muscle that works like a suction pump. And what this means is that we always think of the heart as pumping, and then relaxing, but in fact it doesn't exactly relax. It'll pump and then it will suck, so that it will go like pump like that. So, and if you put a microphone inside the heart, that's what it will sound like. You'll hear the pumping sound and then the suctioning sound. And the sucking draws blood into the heart more quickly and therefore improves the efficiency of the function of the heart. The cardiac cycle is divided into what are called phases, 2 phases, systole and diastole. In systole is when the heart is pumping blood out to the body or to the lungs if it's the right side. But in diastole, the heart is relaxing, not really relaxing, but actually partially relaxing and partially suctioning and filling up with blood. A normal resting heart rate is about 50 to 100 beats per minute, and the heart pumps about 2 to 2.5 ounces of blood with each beat in a relatively normal-sized individual. And this is pretty amazing, I think. That turns out to be over 1 gallon of blood a minute at rest, every minute of your life. So the heart is an extraordinary machine that's able to pump 1 gallon of blood every single minute, at least for your entire life. And that's just when you're resting. If you exercise, then the heart beats harder and faster, and you can increase the amount of blood that the heart pumps by as much as 3 or 4 times, so 3 or 4 gallons per minute in somebody who's in good physical condition. A normal adult blood pressure is divided into 2 numbers, upper number and lower number. The upper number is the systolic blood pressure. That's when the heart is beating, and a normal range is 90 to 140. The lower number is when the heart is relaxing, not pumping, and the normal range for that is 60 to 90. So we consider the upper limit of a normal blood pressure to be 140 over 90, roughly. Okay, so that's general background about the heart, and now I'll talk a little bit about what happens to the heart and the blood vessels as people get older. And this is something that's been pretty well studied over the past several decades. We have a pretty good idea what happens to the heart. We don't know exactly why, but we know what happens. We can make the observations of what happens to the heart as it becomes older. So first of all, both the heart and the blood vessels become stiffer with age. And this is similar, not exactly the same, but similar to what happens with the joints and the muscles. So the joints and the muscles get stiffer as you get older. Same thing happens with the heart and the blood vessels. And this has some important effects on the overall function of the heart. The systolic blood pressure, remember that's the upper number, gradually increases with age, and I'll show you, I think the next slide, an example of that. The diastolic blood pressure tends to peak in about late middle age, 50s, 60s, and then gradually falls off. And both of those effects are related to the increased stiffness of the blood vessels. During systole or during contraction, the heart has to work harder to overcome the increased resistance from higher blood pressure. So the heart, when the heart beats, it's pumping against the blood pressure, and if the blood pressure is higher, it has to work harder. So the heart essentially works harder, gradually harder, as people get older as a result of that slow rise in blood pressure that occurs. The heart muscle also tends to get stiffer and to thicken, and the pressure inside the left ventricle, the main pumping chamber, tends to rise slightly. And this is a simplified explanation, but these changes can contribute to increased shortness of breath with exertion, and this is in completely normal individuals, not individuals who have other types of disabilities. But even in normal individuals, as people get older, they tend to get more short of breath with significant activities, and to an increased risk for a condition known as atrial fibrillation. How many have heard of atrial fibrillation? Almost everybody? Okay, good. So atrial fibrillation is a rapid and irregular beating of the atria, the upper chambers of the heart. It's very common, becomes increasingly more common as people get older. So let me just show you some data on this. This is in the US, average blood pressures in men and women, blacks, whites, Hispanics, with increasing age. This pointer doesn't work so well, so I can't point, unfortunately. But you can see the top on both the men and the women is the systolic blood pressure gradually increasing from 20s up to age 80 or so. The diastolic blood pressure peaking around 50 to 60 and then gradually decreasing after that. And this is a normal age-associated change in the blood pressure. And atrial fibrillation becomes increasingly more common with age. This shows the distribution of atrial fibrillation in the U.S. population. And you may not be able to see it, but the three bars at the right are 75 to 79, 80 to 84, and over 85. And you can see, first of all, that the number of people with atrial fibrillation increases quite strikingly with age in general, and particularly after age 75, so that about half of all atrial fibrillation in the United States occurs in the 6% of the population that are 75 or older. And I should have mentioned this earlier. You might ask the question, well, when did these effects that I'm talking about of age on the heart become noticeable? And the answer is that after about age 65 to 70 or so, most people will exhibit some effects of aging on the heart. It will become apparent. And definitely after age 75, there'll be significant age-related changes that can have an effect on heart function, increasing risk for atrial fibrillation. And I'll talk more about some of the other changes a little later on. Second major change is that the maximum heart rate decreases with age. So when you exercise or are under any other kind of stress, whether it's emotional stress or stress of illness, your heart rate will normally increase. There'll be increased demands for blood, and so your heart rate will increase to try to increase the amount of blood that the heart pumps. And it turns out that this fairly simple formula is one that we use in cardiology every single day to predict what an individual's maximum heart rate might be. So its maximum heart rate, peak heart rate, can be approximated in both men and women by the formula 220 minus age. So if you're 20 years old, you can get a maximum heart rate of about 200 or so. If you're 80 years old, your maximum heart rate's only going to be about 140. And that matters because the amount of blood that the heart can pump, which we refer to as the cardiac output, is equal to the heart rate times the stroke volume. The stroke volume is the amount of blood that is pumped with each beat. I said before, about 2 to 2.5 ounces or so. That doesn't change much with age. And so this effect of age on heart rate means that the maximum cardiac output decreases progressively as people get older. And this actually has some interesting implications. So if you think about sports and professional athletes, you think about which sports are most demanding on physical conditioning, which require the greatest amount of cardiac output, and it's actually hockey. There's the hockey players, they jump on the ice and they're going full tilt for however long their shift, not the goalie, but the guys on the ice. And what happens is that most hockey players are through by early 30s. They can't compete with the younger guys. And that's because even in going from 20 to about 30, 35, they've lost a certain amount of their peak cardiac output, so they no longer compete with the young studs that are coming up at late teens, early 20s. And so, Gretzky made it into his mid-30s, but he's an unusual case, and obviously outstanding player. Most hockey players don't make it that long. Basketball players rarely make it past 35. Baseball players, not so demanding, so they can play into their 40s. And then golf and bowling, not very demanding at all, and so you can be a good golfer into your 50s and even 60s. So it has some interesting effects, this effect of age on maximum heart rate. And the net effect, as I've already suggested, is that the maximum cardiac output, the maximum amount of blood that the heart can pump, and therefore your maximum exercise capacity inevitably declines with age. And among other things, I'm a runner and run in various races, and we have age-graded groups. So I don't run with the 40-year-old guys anymore. I'm running with the 60-year-old guys, and our times are slower, and they give awards for winning 60. I don't win many, but you follow me anyway. You have to adjust for the capacity that an individual has, which declines with age. Another change is that the electrical system function also declines with age, and in particular, there's an increased risk for a slow heart rate, which we refer to in medical terms as bradycardia. Fast heart rate is called a tachycardia, but slow heart rate is increasingly common with age. Symptoms of slow heart rate, if it's too slow, include weakness, fatigue, dizziness, falls, fainting, and unless there's some reversible cause for a slow heart rate, the treatment for it is going to be putting in a pacemaker. And a pacemaker can regulate the heart rate and ensure that it doesn't go below a certain level, 60 or 70, depending on how the pacemaker is set. And because of the fact that this slow heart rate is such a common effect of normal aging, it turns out that about half of all pacemakers are inserted, again, in the 6% of the population who are 75 years of age or older. Another effect is the peak blood flow to the heart declines with age. I had mentioned earlier that, that the heart requires blood, and as the heart rate increases, it requires more blood to meet the demands. But this decline in blood flow to the heart it only occurs with stress. It's not a problem at rest or during normal activities. However, in times of stress, the heart may become deprived of a sufficient supply of oxygen, and in severe cases, injury or damage to the heart muscle may occur. This is a different type of a heart attack than I talked about before, but any injury or damage to the heart can be referred to as a heart attack. And this is something that can happen, for example, if somebody's had a major operation, they're 80 years old, they've had a major operation, that puts a lot of stress on the heart, and we can check certain blood tests after the surgery, and sometimes we'll see an abnormality indicating that there's been some injury to the heart. And the likelihood of seeing something like that increases substantially as people get older. So the risk of heart attack increases progressively with age, and more than half of all deaths due to heart attack occur in people 75 years of age or older. And then the final change that I'm going to talk about is there's several key reflexes that decline with age. Most people, when you think about reflexes, you think about the doctor hitting your knee with a hammer and your leg jumps. That is one type of reflex. But there's all kinds of reflexes in the body that govern pretty much all of our activities. So just as an example, if you exert yourself, you'll start breathing faster. Now that's not something you decided to do. You didn't say, oh, I'm exercising, so I need to start breathing faster. That happens automatically. That's a reflex. Another important reflex is that there are pressure sensors in the neck that sense ongoing all the time the blood flow to the brain. And if there's a decrease in blood flow to the brain, they're very sensitive to that, and they will cause a reflex to stimulate the heart to beat harder and faster to improve the blood flow to the brain. Now this is something that all of you have experienced. If you get up quickly, you'll feel a little lightheaded. And when you were young and that happened, it was very transient. You didn't even notice it. It'd be very slight, and you'd go on your business. As you get older, it tends to last a little bit longer. system is slower to react, and the strength of the reaction is not as strong. And so older people are at increased risk for experiencing lightheadedness, falls, and fainting with changes in position, for example, bending over and then standing up. And that is independent of any other problems that the person might have, neurological problems, and also any medications they might be on that could aggravate this type of condition. And many medicines make these matters worse. And so the bottom line, putting all of these age-related changes together, is that the ability of the heart and the cardiovascular system to respond to stress declines with age. And that is nicely shown in this study referred to as the Baltimore Longitudinal Study on Aging that looked at maximum exercise capacity, what's called VO2 max, in healthy subjects as a function of increasing age. And you can see in men and women, these are healthy individuals, they don't have heart disease, they don't have any other medical problems, that by the time they reach the age of 80 plus, their maximum exercise capacity is at best half of what it was when they were in their 20s. And so this translates into the ability of the system to respond to not just exercise, but any other kind of stress, such as illness or emotional stress or whatever. So that a person who's in their 80s, who's undergoing a major operation, is more likely to have a cardiac complication than somebody who's in their 30s or 40s. It doesn't mean they're at high risk, it just means that the risk is higher than it is when they were 40 years younger. And so that's normal aging, and I suppose it's a little discouraging. We live with it every day, though, and really don't think much about it. But it does raise the obvious question of whether or not there's anything that can be done to slow or reverse the aging process. And briefly, there have been 3 different types of strategies that have been studied for reducing the effect of age on cardiovascular system, and these can be broken down into medications, diet, and exercise. I'm going to touch briefly on each of these. As far as medications are concerned and supplements, this is a multi-billion-dollar industry in the United States. You hear and read all the time about these great remedies, memory enhancers, sexual function enhancers, skin enhancers, et cetera, et cetera. Unfortunately, there's no convincing evidence that any of them work, and so my advice would be to don't waste your money on these products. If you think if you're using them and you think they're helping, fine, I don't have any objection to them, but the evidence doesn't show that they actually work. What about diet? A healthy diet is definitely prudent and is associated with lower risk of heart disease and cancer. The so-called Mediterranean diet, which has received a lot of press over the past few years, and is basically a diet that is high in fruits and vegetables and whole grain products and olive oil and wine, is definitely been associated with reduced risk of heart disease. Vegetarians tend to live longer than people who eat a lot of meat, and very low-calorie diets have been shown to slow aging in laboratory animals, several different studies, but the jury's still out on the benefits in humans, and very low-calorie diets are also extremely difficult for most people to follow. There's food everywhere, and none of us wants to not eat, so it's difficult. But there is evidence, at least in animals, that it will slow the aging process. So the bottom line is that diet does matter. To some extent, you are what you eat, and therefore following a prudent diet is helpful, not just for the heart, but for other organs as well. And what about exercise? Regular exercise does reduce the risk for heart disease and cancer, and helps control blood pressure, cholesterol, diabetes, and overweight obesity. People who exercise regularly do tend to live longer. Exercise has favorable effects on some, but not all of the effects of aging on the heart and blood vessels that I talked about before. For example, exercise has no effect whatsoever on that 220 minus age formula that I showed you. I exercise regularly, and my maximum heart rate is exactly what it would be predicted to be, 220 minus my age. So it doesn't affect that. It does have favorable effects on the stiffness of the blood vessels, though, and certain other age-related changes that I mentioned. So exercise is definitely good from perspective of blunting the aging effects. And as shown, exercise blunts the bad effects of normal aging on the heart's ability to respond to stress, and conversely, lack of exercise tends to accelerate the aging process. And Dr. Wice is going to discuss more issues of exercise in post-polio population. So exercise is good, and what exercise basically does is it puts you ahead of the curve at all ages. So if you exercise, then you're going to be higher than men and women at similar age, therefore have more reserve capacity and be better able to tolerate any kind of stress, such as illness or psychological stress or whatever. The components of an exercise program generally considered to be 4 types of exercise that need to be integrated into an overall program. Aerobic exercise, which is continuous motion exercise, and typical examples are walking, running, cycling, swimming. Current recommendations are for 150 minutes per week at moderate intensity, which is appropriate for most individuals. That's 30 minutes 5 times a week, or 75 minutes per week at vigorous intensity, so that would be 15 minutes 5 times a week, or 25 minutes 3 times a week. Strengthening exercises are particularly important as people get older, and if there's muscle weakness for whatever reason, to try to preserve muscle strength as long as possible. Stretching and flexibility exercises, and balance and agility exercises. How many people do any kind of regular exercise currently? Great. So some tips that for those of you who already exercise, probably redundant or unnecessary, but basically select an activity or activities that you find enjoyable. Exercise should not be considered painful or a chore. If it is, then it's going to be difficult to sustain it. And really, the main and most important point about exercise is that it needs to become a habit a lifelong habit in order to remain beneficial. Start slow and easy, whatever that is for you as an individual, and increase very gradually. Consistency is the most important thing. Frequency and duration are more important than intensity, and so you often hear this myth about no pain, no gain. That's absolutely wrong. You benefit from any kind of exercise, and it not only doesn't have to be painful, but shouldn't be painful. The goal, again, is at least 30 minutes, at least 5 times per week, and then if you're interested in improving your conditioning further, at that point you can increase the intensity, meaning work a little bit harder. But that's not critical for a conditioning program. The key point, I think, is that any exercise is better than no exercise, and at least up to a point more is better. There is evidence that there's such a thing as too much exercise, overdoing it, but for most people, moderate amount of exercise is going to be beneficial. And then finally, just a quick comment on some other health behaviors. Tobacco is definitely harmful for the health and for the heart. It accelerates aging, increases risk for heart disease, stroke, cancer, and lung disease. I think nobody should smoke, and anybody who smokes should quit. Alcohol in moderation is healthy. That's the good news. Up to 2 drinks per day in men and 1 drink per day in women actually have been associated with improved longevity. People live longer. And in American Heart Association and European Heart Association guidelines, moderate alcohol intake is actually considered a healthy behavior, opposite of smoking. There isn't anybody that I know of that necessarily recommends that people who don't drink start drinking, but definitely if you drink at this level, and there's no reason not to, it's certainly not unhealthful to do so. The question often arises about wine and red wine in particular. Is that better than other forms of alcohol? There's some evidence to suggest that that might be the case, but it's not very convincing, and so I think that it's probably the alcohol, and it doesn't make that much difference whether it's wine or beer or liquor. Recreational drugs, the long-term health effects of marijuana are actually unknown, and this is obviously important as marijuana is now legal in some states, and is likely to become legal in other states as time goes by. But there haven't been many good studies of long-term effects of marijuana on health, and so we really just don't know for sure. But other drugs are clearly harmful, especially cocaine has very bad effects on the heart, both acutely during use and then during long term. So I'll stop at this point, and I think we'll have discussion at the end, right? Okay, and turn it over to Dr. Wice. Thank you very much for your attention. Escape. And then you have to go down to the bottom and pull yours up.
Okay, now I'd like to talk more specifically about exercise and individuals who've had polio. I'll go back to early on when individuals actually had the acute polio attack. Polio is an enterovirus. About 90–95% of the people have no symptoms. 4 to 8% have like a flu-like syndrome. And of all the total people who get polio, only 0.5 actually get the paralytic polio, which unfortunately is a large number of the people here. Individuals were hospitalized. They went through intensive therapy. They had bracing, they had surgeries, and made an incredible recovery for the most part, living very functional, productive lives. And the healthcare profession thought that once you had the polio and went on with your life, that would be the way you would be the rest of your life. But it turned out that was not the case. There's a subset of individuals who had polio, anywhere from 25 to 65%, who were getting new problems. And this is a letter by Larry Schneider, who wrote to the Rehabilitation Gazette, which is part of the forerunner of Polio Health International. And what he reported was, it's now 40 years since I contracted polio at age 17. During the past few years, I find myself being able to do less and less and tire far too easily. This led to my early retirement when I was no longer able to stand from my wheelchair by myself, no longer able to walk with crutches or get out of bed alone. Other people started reporting similar issues going on, and this led to the realization there's our late effects of polio. We could now call this the post-polio syndrome, and the definition from the March of Dimes is, number one, you've had to have polio, because I had many people come to my polio clinic who never had polio, and I had to inform them, you can't have the post-polio syndrome. There has to be a period of partial or complete functional recovery, and then a period of neurologic stability, usually 15 years or longer. And then there's a gradual, or there can be a sudden progression of weakness. There has to be new weakness or fatigability. And it could be fatigue, muscle atrophy, muscle or joint pain. And some individuals get breathing problems, swallowing problems, as well as sleep problems. And people often talk about being very active, maybe working in their lawn, doing some construction work, and hitting a wall, where it's like having a severe flu. They're just exhausted, severe aches, and really can't do much. The good news is that after usually a day or two, that resolves and they're back to their baseline. The symptoms have to be present for at least a year, and there can be no other explanation for those symptoms, which is often the hardest part for a physician to make the diagnosis, because it's a diagnosis of exclusion. I can't do one test and say you have the post-polio syndrome. I have to do an exam and multiple tests to say there's nothing else obvious going on, and how much is enough, how much testing do you do? So people were afraid to be overly active at first, and people tended to become more like couch potatoes, but that is also not good. Inactivity can be just as devastating as overactivity. And there have been studies done on inactivity and bed rest, and you can see deterioration in the cardiovascular efficiency, loss of strength and endurance, loss of flexibility, metabolic disturbances, loss of calcium, etc., trouble maintaining a normal body weight, sympathetic nervous system changes, emotional disturbances. And looking at just healthy individuals, not those that had polio, but those who were healthy and just put at bed rest, they looked at their Vmax, which is their oxygen capacity. It was reduced by 16%, and that's healthy people. The cardiac output, which Dr. Rich talked about, dropped 30%. Again, just for not being active, bed rest. He had muscle atrophy, the organelles in your cells, which are the factories that help oxygen used in making energy, the density is reduced, the volume is reduced, the enzymes that help with oxygen and energy production are reduced. And just looking at strength alone, with bed rest, you lose 10 to 15% of your strength per week. So after 4 weeks, you can lose 35 to 40% of your strength. And if you just do minimal exertion, your strength can be reduced 25 to 40% in 2 to 3 weeks. So the opposite of not being overactive, being inactive, is also not good. The other issue is cardiovascular issues, the post-polio syndrome. Now there's reports that people who had polio, post-polio syndrome, are more prone to various medical conditions, including heart disease. I've not been able to find data to give you a percentage for, in the U.S., of the actual cardiovascular disease in individuals who had post-polio syndrome. But there is a strong suspicion that individuals who've had polio are at a higher risk of cardiovascular disease. They're not as active as they would be as an individual who has no muscular compromise. They may be obese. They tend to be more prone to hyperlipidemia. They may have less ability to breathe effectively and have an element of hypoxia. And the average ability for a person with post-polio syndrome to move about, the maximum capacity, which you can measure, is called METS, is equivalent of walking 5 miles per hour, going up and down steps. Now, the one good news is that the polio has not affected the autonomic nerves, despite the peripheral muscles being affected, which means that if you want to use heart rate, a determinant of exercise, that's still a very effective tool, but that would not be affected from the polio. So the question is, if we push an individual with polio, pushes them real hard, are they going to hit that wall? Are you going to have deterioration actually do worse? Or can we give some exercise and hope that their cardiac status improves? And there were 2 classic studies which addressed that done at the Sister Kidney Institute in Minneapolis. The first one by Dr. Jones. He took 16 subjects with 21 controls and had them exercise on an exercise bike. They had to have enough strength where they could raise their hips and extend their knees, at least anti-gravity, and could at least bend their hips back or flex their knees with gravity eliminated. They could wear braces on their ankles if they needed to. They had to be relatively healthy, and they tended to take younger people. They wanted them to keep it under 60 so that they eliminate cardiovascular disease as an additional factor. I just wanted to look at polio, post-polio syndrome and exercise. And they had individuals exercise at 70% of their maximum heart rate, which is again 220 minus your age. And they set it out with a slow warm-up and a gradual increase in activity on the exercise bike. And they had individuals exercise 2 up to 5 minutes, then took a 1-minute rest, and did it over again, starting out closer to 15 minutes and trying to work up to 30 minutes per session, doing 3 sessions a week. I did it for a total of 16 weeks. And they found that there was an actual positive exercise effect, that those individuals could work more effectively. The change for the control versus the exercise group was 7.5 to 22 watts. The exercise time improved. The amount that they could exhale improved, and the VO2 max, of the exercise oxygen capacity, improved 15%. And the additional good news was no one had any type of significant deterioration. The post-polio syndrome did not become worse. And then Grizz did another study, this time doing arm ergometry, and essentially the same study, but people who couldn't use their legs but could use their arms. And again, they did it, exercise 2, 3 up to 4 minutes at a time on an arm ergometer, had 1-minute rest, did 15, trying to work up to 30 minutes. The majority averaged around 20 minutes, 3 times a week. In both this group and actually the last group, they had their initial exercise program developed with therapists. They had to go back 1 session a week to make sure they were doing things right, there were no complications. And again, this study showed that exercise did help those who had post-polio syndrome. They had more power, they could exercise longer, they could breathe better, and they had a better oxygen capacity. And in addition, they had no significant problems with overuse problems, pain, excessive fatigue, weakness. So these 2 studies, some other studies, indicated that yes, you can do exercise if you had post-polio syndrome. And indeed, there have been other studies with exercising for strengthening and other things with post-polio syndrome, and I'd like to summarize my talk by reviewing exercise in general that individuals that had post-polio syndrome. This is a statement from Post-polio health. Current evidence suggests that exercises are often beneficial for many polio survivors, provided that the exercise program is designed for the individual following a thorough assessment and is supervised initially by knowledgeable health professionals. The danger is you go to somebody who thinks you're a linebacker for the Chicago Bears, puts you through a very rigorous program. You get overuse syndromes, you get injuries, aches and pains that do not go away. You actually do lose strength. So you need someone who's aware of the post-polio syndrome and can customize your program, particularly since when you had the polio and you lost strength, it can be very spotty. So you have to customize each individual's program to make sure you get the maximum benefit, but usually using muscles that are at least can work against gravity. And again, exercise programs can enhance a polio survivor's health, range of motion, activity capacity. The exercise program should be low to moderate. There's a recent study in the archives of physical medicine and rehabilitation this past January, which showed that moderate intensity exercise worked well, and indeed it was the most accurate way to determine your exercise capacity. And something I learned early on treating post-polio patients, listen to your body. That still exists, and they found that a Borg setting of 12, which represents your self-perception of exertion, is probably close to optimal for people who've had who are exercising with post-polio syndrome. It gives them most accurate feedback of your anaerobic capacity. And 12 is, there's 6 is the lowest, which is equivalent to lying down on the beach and drinking a margarita. And 20 is a grizzly bear is chasing you, running for your life. And 12 is where you should exercise. You should also progress slowly, especially if you're starting out. You need to pace yourself. Do some, take a break, do some, take a break. And you can rotate the type of exercises you do, stretching, aerobic conditioning, what we talked about today, strengthening, endurance, range of motion exercises. And lastly, if you experience severe pain or marked fatigue, especially if it doesn't clear up within 1 or 2 days, that indicates there's something happened that shouldn't have happened. You need to seek medical attention before you resume your exercise program. So with that, we'll take questions. Okay, thank you very much.
I had a question about, you used the term that there were no overuse symptoms, and I didn't know the definition, if that was restricted to overuse symptoms on just the heart or the overall muscle system in the body.
It was for the overall muscle system, not excessive pain, fatigue. I'm sorry. The question was, do these cardiac exercises post-polio people did or did not cause overuse syndromes? It did not. And by overuse syndromes, I mean the post-polio, worsening of the post-polio syndrome symptoms. You didn't have inordinate pain, did not have inordinate loss of strength, didn't have muscle atrophy. People could tolerate the program well. You did not make the post-polio syndrome worse. The question is polio and the heart muscle. And does the polio affect the heart muscle? My understanding is it does not.
No, my question was, why does it affect our other muscles, but it doesn't seem to affect our hearts?
So the reason it doesn't affect the heart, like the other muscles have direct innervation, usually from the spinal cord, where the anterior horn cells sprout out the nerves to your muscles. You can consider that to be the wires. When you have the polio, it attacks those anterior horn cells and it will kill off some of those nerve fibers. They go into the skeletal muscles. And that's why they're damaged. That's why you have loss of muscle mass and loss of muscle strength. And the initial recovery is some of those surviving nerves will actually send out new sprouts and go into the muscles that were, or fibers that were actually orphaned and lost their connection. And then they reconnect, and then the muscles are able to fire again.
So you're saying that someone who had polio and is experiencing post-polio and is starting to have heart problems is probably an aging factor?
Well, this is not due to the polio alone. It's other factors. You would not assume it's, the question was, if someone has heart problems, if an individual who's had polio, should you assume the polio helped precipitate the heart problems? The answer is no. You have to assume it's a problem independent of the polio, even though the lifestyle change, the deconditioning can make you more prone to cardiovascular disease, but it's indirect. The question was bulbar polio, which affects swallowing or talking, and having also additional breathing problems. Can that affect the heart? Indirectly it can, if you have hypoxia or right heart failure, but it doesn't directly cause heart disease. It could indirectly.
How long does it take to have your carotid artery clear up, not by medicine, but by changing your lifestyle?
So the question, as I understand, was how long it takes for the carotid artery to become clear of cholesterol buildup through lifestyle changes and that sort of thing. And I think that the question could be extended to what about if there's blockages in the coronary arteries. And the fact of the matter is that lifestyle modifications aren't very effective in reducing those blockages. They are helpful in slowing the rate of progression of those blockages, so a healthy diet and not smoking and all the things that I talked about are the best things that one can do to reduce the likelihood that it's going to get worse. There is some evidence that, particularly from Dean Ornish, and many of you probably heard of Dean Ornish, he publishes books on heart-healthy lifestyle and so forth, that his program has been shown to lead to some reversal of blockages in the coronary arteries, and I would expect the same thing would occur in the carotid arteries. His program is extremely rigorous, though. It requires a vegetarian diet with less than 10% of calories from fat. There's also regular exercise, meditation, and various other things. It's sort of California in a sense, and it's I think a very difficult program for most Americans to follow, but the people who are able to follow it have gotten some reduction in the amount of blockage that they've had over a period of, to more specifically answer your question, 4 years. So they did an angiogram of the heart, showed the blockage, went on the program, repeated the angiogram 4 years later, and it was better. So over a 4-year period, they got some improvement.
On that
So the question has to do with the calcium level and whether that contributes to this buildup of cholesterol and calcium in the arteries, and whether supplemental calcium and vitamin D can aggravate that condition, and therefore if stopping supplemental calcium and vitamin D can help the process. Is that the question basically?
And taking K2 to remove the calcium.
By K you mean potassium?
K2.
K2. I don't know what K2 is. Sorry. K2, do you know what that is? All right. It is true, first of all, that high levels of calcium in the blood can contribute to calcium buildup in the arteries. There's various conditions, medical conditions that do that. It would be unusual unless someone is taking large amounts of calcium and large amounts of vitamin D to have a high calcium in the blood just from supplements. But you might get a small increase as a result of that. Stopping them might allow the calcium level to drift down a little bit. Whether or not that's going to have much effect on the buildup of calcium in the arteries, I'm not so sure about. I don't know that any studies have looked at that, but
A repeat test of the carotid artery would show that.
would it show that? It would show if it's changed, yeah. Yeah.
I just wondered, how do you find a qualified exercise coach, fitness trainer, somebody in PT who really knows post-polio and deal with that? What questions should you ask them? How do you find somebody?
The question is, how do you make sure you get someone who knows what they're doing with post-polio individuals? And the best way is to ask how many people they've seen, if they've been to conferences, see if they're associated with a clinic that deals with people who have had post-polio syndrome. And sometimes you have to educate them. Sometimes Polio Health International is a good source. They can send them information, because a lot of them are open to learning. They're just naive. They don't know what to do, what not to do. But given appropriate guidelines, they could be an asset.
To follow that up, I'm a physical therapist in Houston, and Houston is a huge metropolitan area, and I have a handful of clinicians in my community that I know that I can reliably send people to for physical therapy. And similarly, we get a lot of people from out of town, out of state, and sometimes even out of the country. And so when people come back for follow-up and I find out that they did have physical therapy, I said, well, how was your experience? Was the person knowledgeable? Were they willing to work with you? And then I collect business cards and contact information so that when my next person from Louisiana comes, I can say, well, do you live anywhere close to this particular place? And I'll give them that contact information. But again, it's, there's nothing official. I do refer them to the Post-polio Health International website because there is the directory of providers. There's no checking of the people that are listed on there other than people know that directory exists to put themselves on there. It's a lot of work now. And the funny thing is when people retire or move jobs, they don't tell me that they're moving jobs and retiring. So sometimes we get stuff.
And sometimes your local post-polio support group can be a good resource for finding such a physical therapist as well.
I'm wondering if there's no medical reason for it. I mean, I was on some heart medicine, but there's no medical reason and you're not sick or dizzy or lightheaded. Is it okay for your blood pressure to routinely be below 100 systolic and diastolic?
The question was, can you have suddenly, quote, low blood pressure as long as you're totally asymptomatic? And the answer is it's okay as long as you're totally asymptomatic.
It's good, actually. It turns out that as a general principle, if a person is healthy and not having any symptoms, that lower natural blood pressure is associated with lower risk for heart disease and stroke. So it's favorable. And when I said the normal blood pressure of, for adults of 90 to 140 systolic, that is the normal range, but that doesn't necessarily mean that less than 90 is abnormal for a given individual, and particularly younger women often will have blood pressures in the 80s, less commonly in the 70s, and they're perfectly healthy. So, yeah, as long as you feel fine, pressure in the less than 100 is fine.
Read anything regarding the effects of blood pressure or cholesterol-lowering medicine on post-polio patients regarding muscle strength?
I couldn't hear the question.
Issue of statins. Well, the question is, are statins good or bad for individuals who have muscle disease? And the answer is statins can cause muscle problems in a small percentage of individuals. There's no right or wrong answer. The question is the beneficial effect worth trying it? If you feel fine taking it, it's probably okay. If you feel that taking it, you notice a deterioration for any reason, I tell all my patients, you have any side effects from any medication, stop taking it and call me. But if you feel you're getting weaker, having muscle aches, you should stop taking it and call your physician.
She indicated to me that the muscle strength would return once I stopped with the drug. Does that sound right?
As far as muscle strength, you turn out to stop the statins. That's usually the case.
So I agree with what Dr. Wice said fundamentally, and I think that it can be a difficult trade-off. So if somebody is post-polio and also has high risk for heart disease or already has heart disease, let's say you already have had a heart attack and have known blockages in there, then it's possible that that the benefits of being on a statin and lowering the cholesterol and lowering the risk for another heart attack, possibly lowering the risk for a stroke, outweigh the potential risk of having muscle problems from the statins. Statins definitely can do that, and probably in the range of 5 to perhaps 20% of people will have some muscle side effects. These are not people with polio, just in the general population, people taking statins. So my feeling would be that I would probably be inclined to recommend avoiding statins in individuals post-polio who have ongoing muscle problems, weakness, unless there's a pretty strong indication or reason for taking the statins. You know, the most recent cholesterol guidelines recommend considering statins for a large proportion of the population, but it always has to be considered what the potential benefits and what the potential risks are. And so I think the potential risk for a muscle problem is likely to be higher in the post-polio population. So I would be less inclined to prescribe a statin in that situation, except in a very high risk population. But also, even in that population, if there are side effects, then that still might, and particularly if the side effects are more disabling than the heart condition, then that would be a reason for discontinuing.
Are all statins the same in terms of their effect on muscle fatigue, or is it worthwhile kind of trying different things?
Yeah, so the question is, are all statins the same with respect to the muscle effects? And the answer is no. First of all, there is a dose effect, so that for any given statin, the higher the dose you take, the more chance there is of having muscle side effects. But also some statins are less prone to cause muscle side effects than others, and I have to be honest, I can't remember all of the details about that. Fluvastatin is one of the statins that's less likely to cause muscle side effects. Pravastatin also is less likely than some of the other ones, but the more common ones like atorvastatin, Lipitor, simvastatin, which used to be Zocor, I honestly can't remember. The high doses of Zocor definitely have been associated with muscle problems. And so in this population, that is one that I would avoid simvastatin. I would use one of the other ones that I mentioned. Marty, do you know any more? I'm sorry?
What's an alternative then to statins?
Alternatives to statins. So from the heart point of view, none of the other available drugs have been shown to be anywhere near as effective in either improving the cholesterol levels or in reducing the risk of heart disease, which is really the bottom line. So you could have a drug that reduces the cholesterol level, but if it doesn't prevent heart disease, then what good is it? And so statins are by far the most effective. They're definitely proven to substantially reduce risk of heart disease when taken appropriately. And there aren't any really good alternatives. So what do we do in practice? So what do I do if I have a patient who I think should be on a cholesterol-lowering drug, can't take statins? That happens commonly. I have a lot of patients who can't take statins for one reason or another. I tend to use a drug called Zetia or ezetimibe, which is less potent than statins, but does provide some cholesterol lowering. The vitamin niacin also is effective. There's other drugs that work in the intestine, cholestyramine and cholestid, which are powders that bind cholesterol in the gut. Those can help lower the cholesterol. There's a drug called Welchol. All of those drugs are less effective than statins. They have their own potential for side effects, but usually not muscle problems. And so those are alternatives. There are some new drugs under development that are even more potent than statins in terms of lowering cholesterol. They're not available in the U.S. at the present time. They're still under investigation. But it's possible that within the next 5 or 10 years we'll have some good alternatives to statins. Aspirin. So aspirin has no effect on cholesterol. Aspirin in low dose in higher risk individuals does seem to prevent heart attacks. And the downside of aspirin is that it also is associated with bleeding complications. So aspirin has become more controversial recently. 10 years ago, there was no question about aspirin for anybody who is at moderate or high risk of having heart problems. Now, the pendulum has swung a little bit the other way, and aspirin is still being recommended for somebody who's had a heart attack or who's had an angioplasty or a bypass operation, but not necessarily for anybody who might be at risk. So people with diabetes, for example, we used to routinely recommend aspirin, but we don't necessarily recommend that routinely anymore for that.
What do you know about Lescol XL in cholesterol?
What's the name?
Lescol XL.
Lescol. So Lescol is actually fluvis.
What would the XL?
Yeah, that's just extended release, extended duration. The XLs and the XRs, that means it's long-acting, basically. Yeah, extended length of duration. But Lescol is fluvastatin. It's the one I mentioned earlier. It's fluvastatin. It's a statin.
It is still a statin.
It's a statin, yeah.
But does it affect the muscle?
Pardon?
Does it affect the muscle?
So that's one of the ones that I think has less effect on muscle. Yeah.
So this is, yeah.
I know this should make a difference, but I have been on the Symbastin, Zocor, for a number of years and had no problems with the muscle anxiety and muscle pain. And when they came out with the generic, the insurance didn't want to pay for it anymore, made me try the generic. And they put me on the generic protocol, and they tried the generic Zocor, and my muscle anxiety and muscle pain went shot through the roof. So the doctors had to go back and put me on Crestor, which is not going to generic available because my insurance would pay for that. And I don't seem to have problems with it on the generics.
Yeah.
And I don't know
And
what it's supposed to be equivalent, but they shoot through the roof when you give me the generics.
yeah, you're not alone in that problem. There have been many people who've had problems with the generics who never had problem with the brand name. And as you may know, recently in the news there have been a lot of investigations about some of these generic products made outside of the U.S. that are not meeting the U.S. standards and aren't working as well or having more side effects or so forth. I don't know if that was the case with the Simvastatin that you were taking, like where it was made. Yeah. But there has been some problem with the quality of the generics in terms of both efficacy, how well they work, and potential for side effects. So yeah, if it's causing problems, whether it's a generic or a brand name, then yeah, I think you have no choice but to switch to something else and hope that that will work better. You know, atorvastatin, which is the old Lipitor, is also available generic, so that would be less expensive than the Crestor. I can't guarantee you wouldn't have the same problem as you had with the Simvastatin. But
The drug company itself that makes Crestor has given a card that reduces the price beyond what the insurance
Yeah.
pays, and then they give you a card and they reduce it on down some
Yeah.
more, so it's not quite
Yeah.
so bad.
okay.
Is there any definitive level of cholesterol you know is going to cause you trouble?
I'm sorry, say that again.
Any level, the number, definitive number of cholesterol that's going to give you forehead? I mean, it seems like the number keeps going up and down. They say you shouldn't have more on 60, you know?
So you're asking if there's a level of
Is there a level that you know of that is detrimental to your health?
too low?
Too low or too high?
Too low or too high. So, yeah, so cholesterol, there's several forms of cholesterol, as probably most everybody knows. And there's a total cholesterol, which is a combination of all of the forms in the blood. Then there's what's called the high-density cholesterol, the HDL, which is the so-called good cholesterol. And the higher the better that is. Yeah, the higher the better, and there's no limit. So actually, my daughter sent me an email last week asking if her HDL is 102, and she said, "Is that anything to worry about?" It's terrific. It's a fabulous HDL, and is definitely protective for her. So the HDL, the higher the better. The LDL, which is the low-density lipoprotein, is the one that is associated with heart disease and blockages and so forth. And as far as we know, there is that the higher it is, the worse it is. That's clear, and there's no known level that is too low. So see people who have an LDL of less than 40, which is quite low. It doesn't seem to be associated with any detrimental effects. I'm sorry. Yeah, the ratio between the HDL and the and the LDL. So if you look at HDL to LDL, the higher the ratio is, the better, and there's no limit. I tend to not look much at the ratio, but you can look at the ratio, and for HDL to LDL, the higher the better would be good. I just want to say one more thing about that is that the total cholesterol, which is the sum of all of them, I'd say can be a marker of a problem. So there's certain medical conditions, cancer particularly, or some type of a chronic infection such as like HIV, AIDS, in which the total cholesterol will go down. And so if the total, just trying to answer your question, if the total cholesterol starts falling and there's not an explanation for it, then that could be an indication that there's some health problem going on and may or may not warrant some type of investigation. But in that case, there might be such a thing as too low.
I've never had both. I'm here with my sister. In my experience in my life, I'm 74, okay, that blood pressure medicines and cholesterol medicines, they both have, when you read the disclaimers on what they're going to give you, not muscle weakness is at the top of the list of all. So if you take a combination of the two, you can almost definitely, and I know when I used to, that when I took, there was some statin, I immediately lost the effect. Nice to have. But if you take both of them, then you almost expect it to happen.
Yeah, so drug interactions, so the question has to do with combination of blood pressure and cholesterol medicines, and the more medicine one takes, regardless, the more potential there is for interactions between the drugs. And it is true that potential for side effects is higher if you're taking more drugs. There's not, that I'm aware of, Let's think about this quickly. I'm not aware of commonly used blood pressure lowering drugs that aggravate the effects of statins, but there, first of all, might be, and secondly, it can be individualized anyway. So even though it's not a common interaction, it doesn't mean that it didn't happen for you. Yeah. So I think probably we need to stop soon. Maybe take one more question if you like, or we can hang around. And but thanks very much for your